Good evening, everyone, and welcome to the European Heart Journal Dialogue. I am Cecilia Linde. I am the Executive Editor of European Heart Journal for the subject of heart failure. And I would like to remind you that we have a dialogue each month with leaders from cardiology from all the 5 continents. The dialogues are free and live stream in YouTube and X. So we encourage you to use the chat to ask questions, and we will pick them up and answer you on the road in this dialogue. It is now my privilege, my great privilege, to ask Professor Johann Bauersachs, Deputy Editor of European Heart Journal, to start the dialogue with Professor Bertram Pitt, entitled Mineralocorticoid Receptor Antagonists in Cardiovascular Disease. So Johann.
Thank you very much, Cecilia, and really welcome to everybody. And I'm really happy that we have Bertram Pitt here. Dear Bertram, you have already been a giant in cardiovascular research when I started my research on aldosterone and mineralocorticoid receptors 25 years ago. And I was intrigued by the RAL study with spironolactone in HFrEF, which turned out to be a game changer in heart failure. But you started your career, you received your MD from the University of Basel in Switzerland in 1959. You trained in cardiology at the Johns Hopkins University School of Medicine, and you remained there until 1977 when you went to the University of Michigan as professor of medicine and director of the Division of Cardiology, where you are currently a professor emeritus. You have also received Lifetime Achievement Awards from the Heart Failure Association of the ESC and the Heart Failure Society of America, as well as the James B. Herrick Award from the American Heart Association. And just recently, in August this year, you were awarded with a gold medal of the ESC. You have also been principal or co-principal investigator of a number of clinical trials, including SOLVE, ELITE, RALS, Ephesus, Emphasis, TopCat, Figaro, to name just a few. We met several times during the last 25 years, and I'm still admiring what you did and what you still do in aldosterone and MR research. So my first question would be, what brought you towards cardiology? Was this your first choice?
Well, as you mentioned, I went to school at the University of Basel, and in order to graduate, we had to have a thesis. And there was a very young cardiologist, Walter Schweitzer, who had just returned from London studying with Paul Wood. And he was our instructor in cardiology. And I linked to him to do a research project for my thesis. And we worked on the collateral circulation. At that time, there was a lot of controversy as to whether the collaterals were functional or not in the human heart. Dr. Myron Princemetal in California had the view that they weren't really functional. And Dr. Herman Blumgart, who was professor at Harvard and editor of Circulation, believed they did. We did a study with Dr. Schweitzer where we took human hearts and we gave them little microspheres, and we saw that they crossed the circulation. And then we eventually published this in Circulation. And Dr. Blumgart wrote an editorial about it, and that's led me to get my residency at the Beth Israel Hospital in Boston. And on my career to cardiology, after there, I went into the Army, but worked at a research laboratory with a very well-known physiologist, Dr. Donald Gregg, on coronary physiology. And from there, I went to Hopkins and worked with Dr. Richard Ross and did my cardiology fellowship and stayed on the faculty. And as you said, ended up in Michigan in 1977, where I still am. But it was that initial interaction with Dr. Schweitzer, who had just come back from working with Paul Wood, that really got me into cardiology. And it was really a thrilling experience, and I'm still excited about it.
Yeah, great to hear. And your contribution to our understanding of the role of mineralocorticoid receptor antagonists in heart failure is really a milestone in the history of heart failure. How did you get interested in aldosterone and mineralocorticoid receptor?
Well, I must say it was sort of a happenstance. Searle, who owned spironolactone at that time, was trying to get someone to study it in heart failure. They had gone to several of my well-known colleagues and asked them whether they would be interested in running a trial with spironolactone. But at that time, ACE inhibitors and ARBs were just being developed, and everyone was excited about that, and no one thought that spironolactone really was worthwhile. But I had just given a lecture at the American Heart Association about diuretics. And in doing that research, I had found a paper by Jan Stassen in Belgium, where he showed that ACE inhibitors and ARBs were effective in reducing aldosterone levels, but in about half the people over a few months, the aldosterone levels would return to baseline or above. And knowing that, when they asked me, after many people had refused them, I said, yes, I would be interested, because if you can't get rid of it with an ACE or an ARB, I thought it could be important. But before we agreed to do a study, I said it would be very important to do a dose finding study, because at that time, people were using 100 to 200 milligrams of spironolactone for hypertension, but no one was using it, or very rarely was it used in heart failure. So we carried out a small dose finding study where at that time we used atrial natriuretic peptide as the efficacy endpoint and potassium as the safety endpoint, and tried to find some balance where we could find some efficacy with minimal safety risk for hyperkalemia. And we settled on a dose of about 25 milligrams a day, with the ability to go down to 12.5 or up to 50 or even higher sometimes. And that turned out to be really critical, because I think we'd have gone with 100 to 200, it would never have been used, and the trial would have stopped prematurely. And I must say, when we heard the results of the trial, which we heard at the ESC in Barcelona many years ago, we were really surprised. We had always thought it was good, but we never realized it was that good. And when we saw the results on mortality and everything else, we were really a little bit awed and shocked, but obviously delighted.
It was an unbelievable success, and clearly the key to this success was the dosing, so that you didn't use 200 milligrams or 100 milligrams, but only 25 milligrams. And was this then the most important success in the study of antagonists, the primary results of RALs, or did you have other important successes?
Well, this was the major one. And after that, Searle had a new derivative of Plarinone, and they asked me to study that. We decided what to do with it. We had debates where to study it. So we had just done a study in HFrEF, so we decided to study it in post-infarction heart failure. And we did the Ephesus trial, which you know was also successful. And then that was followed, which I worked with Faya Zenad on the Emphasis heart failure trial. So we had 3 trials over several years showing that MRAs were really very good in heart failure, reduced cardiovascular mortality, heart failure hospitalizations, and even total mortality. Now, having said that, to me, it's been a little bit disappointing that despite all of the work we have and all of the evidence, that it's still underused in many parts of the world. It's one of the 4 pillars, but one of the pillars with the MRAs is a little shaky because people don't use it. I think that's a mistake, but nevertheless, it's still a work in progress.
As you just had also a viewpoint in the European Heart Journal, I think last year, on that this is still a Cinderella, the mineralocorticoid receptor antagonist, that also in the study investigating the ARNI post-myocardial infarction, there was only, I think, less than 50% use of the MRA, and also in other post-infarction studies with heart failure, and also in heart failure itself, it's only used occasionally in 1/3 of the patient, especially in US. I think in Europe it's a bit better, but clearly the concept of aldosterone escape, despite the fact that you treat with an ARB or ACE inhibitor or ARNI, is still there, and we should use more the MR antagonists. But now I want to ask you, there are in addition also several aldosterone synthase inhibitor under clinical development. What are advantages or disadvantages of this ASI compared to the MRA?
So that's still a work in progress. So the ASIs are really a great advance, and the new ones seem to be very specific, don't increase cortisol, and we think have a great promise. They've already been seen, 2 of them, been studied in sort of uncontrolled resistant hypertension. But I think it's still too early to be sure. Clearly, I think in primary aldosteronism, they have a great role. But what their role is in heart failure or even in resistant hypertension with chronic renal disease is still uncertain. The reason I say that is while aldosterone is certainly important, there are circumstances where the mineralocorticoid receptor is upregulated. And once the mineralocorticoid receptor is upregulated, in fact, one of the articles you wrote, I think many years ago in Hypertension, talked about the upregulation of the mineralocorticoid receptor. And once it's upregulated, it can be stimulated by cortisol or RAC1. And so even if you get rid of aldosterone, if the mineralocorticoid receptor is upregulated and stimulated by cortisol or other circumstances, you can get inflammation, fibrosis. So I'm not so sure that the ASIs will cure everything. I think there's still a role for MRAs. In fact, there may be a role for the combination. I don't think we know the answers yet. We've seen some very exciting data from the ASIs, but we haven't seen, at least I haven't seen the data in bad renal disease. We don't know the incidence of hyperkalemia from the ASIs when you get a GFR less than 45 or even 60. Most of them have been in studies with good GFR. So I think we need a lot more information. Obviously very exciting, but before we reach any final conclusions, I think we need some further data and maybe some comparative trials. I don't think they're going to replace MRAs completely. They will have a role. I don't know what you believe because you're one of the experts, and I always admired the stuff that you had written, and that stimulated me towards some of these thoughts.
Thank you very much. So I think that this aldosterone independent MR activation is still of importance, and this will not be covered by the ASI. So clearly we have to know more and to have more also direct comparisons. We also have here a question from Professor Frédéric Chaisser from Paris, and perhaps maybe Frédéric, you can just directly ask your questions also relating to novel non-steroidal MRAs that are also important as new advantages over non-steroidal over steroidal MRAs. Frédéric.
Hello, everybody, and nice to see you, Bert. Yeah, you know, I'm always puzzled with the very nice results of the non-steroidal MR antagonists and the difference also on the blood pressure effect between the different MRAs and the different non-steroidal MRAs. And I wonder whether, because there is no comparative head-to-head trials, I wonder whether, what is your feeling about the lower risk, the apparent lower risk of hyperkalemia that has been noticed in the last trial from Bayer, which are clearly there, and the molecule is clearly efficient. But I wonder whether this is due to the very high efficacy and the low dose that is used that may target primarily the long-term effect, for example, on inflammation and fibrosis and remodeling, and rather not on the sodium-potassium balance, which may explain a lower effect on blood pressure, maybe a lower risk of hyperkalemia. And the question is, should we use lower dose of eplerenone to have the same effect?
Well, I think it's complicated, but as you very well know, the steroidal MRAs distribute mainly to the kidney and less to the heart, whereas the non-steroidals are more evenly distributed. And I think that accounts in part for the lower risk of hyperkalemia. Certainly, finerenone has been very successful, and in people with diabetic nephropathy, in the Figaro trial, Fidelio, we saw that it was well tolerated. There was hyperkalemia, but only about less than 2% of people had to discontinue it. As you pointed out, it lowers blood pressure, but not fantastically. But I must say that there are newer nonsteroidal MRAs. One of them we're working with is called Osadon, which we've already published a phase 2 trial about a year ago in hypertension. And that nonsteroidal is being investigated right now in a phase 3 trial. And it looks at the moment as if it is also has a very low incidence of hyperkalemia, but much more effective in lowering blood pressure. So it lowered blood pressure in the phase 2 trial about 10 millimeters of mercury, placebo-controlled. So we have to await the results. It's not yet approved. We're just finished randomization of a phase 3 trial for FDA approval, working with George Bacris. But we have to await, but I think it has lots of promise. So in the future, I think the nonsteroidal MRAs will have a great role because of their better tolerability. And the blood pressure parts, when you're dealing with resistant hypertension or uncontrolled hypertension, I think we'll have agents that are very effective in lowering blood pressure. And we'll have to see how the balance goes and compare it with ASIs. We need more studies comparing the non-steroidals with steroidals. So there's a lot of work ahead, and some of the work you do in animals has been an inspiration to me and helped me to understand where things are going. So thank you.
Thanks.
But Bertram, do you think that there will be also non-steroidal MRAs or ASIs that in fact are as effective as spironolactone in reducing blood pressure?
Well, I think the Osadon looks very, very close. It hasn't been directly compared, so I can't say that for sure. But I just said in uncontrolled resistant hypertension stage 3B4 renal disease, which we published in Hypertension about a year ago, the block CKD trial, we had 10 millimeters placebo-controlled reduction. So I think that's going to be pretty close to spironolactone and much better tolerable.
Coming back to heart failure, you have witnessed the evolution of our understanding of heart failure. And from a historic perspective, what have been the main steps in our understanding of the mechanisms of heart failure?
Well, I think we've gone from a lot of interest in neurohumoral activation, which we still are. And I think there's a lot now on focusing on inflammation. There are lots of studies looking at anti-inflammatory effects, oxidative stress, and new approaches. But I think it's been said many times, if we would just give and use the drugs we have available in our 4-pillar strategy, that would be maybe more important than any new mechanism or any new drug. But certainly there are new things coming and lots of excitement in the future. But it's been disappointing that despite all the trials and evidence, that a lot of people are still not using the 4 pillars adequately. And I understand people's fear about hyperkalemia with MRAs, but I think it's a little bit overblown. There was the study in the New England Journal by Gerlink from Canada where they showed a very high incidence of hyperkalemia. But if you look at that study, people were using very high doses and inappropriate patients often. So I think when you look at it carefully, these agents are usually pretty well tolerated. Sometimes you can't do it, but then there are other ways. We have potassium lowering agents, and in the future, certainly ASIs and non-steroidals. And the evidence is very clear. When you're not using an MRA or blocking aldosterone, you're exposing your patient to increased risk. So if you want to have the optimal risk, you have to get rid of aldosterone because it's elevated and the MR expression that we just said is up. And once that happens, unless you counteract that, you're going to have increasing inflammation, fibrosis, vascular stiffening, and progressive heart failure.
Thank you. Maybe just one question from the chat, just a thought. Could there be another path that then escape MRA blockage? Or another path that escape MRA blockage was the question.
Another path. I don't quite understand what they mean by another path. I mean, we know that the ACEs and the ARBs and ARNIs don't do it. You still get escape, but I don't exactly know what they meant by another path. Do you?
Or maybe another mode of action in addition to the ALDO that escapes. I don't know. I also don't know exactly what he means.
Well, there are non-genomic effects, as we know, and we talked about the effects independent of aldosterone on the MR, but I can't answer it more than that. Without a little more context of the question.
I'm back to Cecilia. Oh, you're muted, Cecilia.
Cecilia, you're still muted.
I have a good question from the chat from Jean-Pierre Benita. What about MRAs and antiarrhythmics?
So there is pretty good data that they do reduce ventricular arrhythmias and atrial fibrillation. So we've seen in the trials, in fact, Carl Svedberg reported from the Ephesus trial, the Ephesus trial rather, that we had a reduction in atrial fibrillation, and there are several studies showing that, and we've seen a reduction in ventricular arrhythmias and sudden death, and I think in part that's related to the effects on fibrosis. The fibrosis is a nidus and stimulus for recurrent reentry, but there are a lot of electrophysiological effects, and people have studied it. So I think it has a clear effect on arrhythmias and sudden death, and I think that's been pretty well documented.
And this effect is independent of the elevation of potassium, or in addition to?
I think that's independent of the potassium, I believe, though I'm not an electrophysiologist, but I think it's independent.
But isn't it so too that MRAs are potent reverse remodeling agents, and that
yes, so
one of the
remodeling, the fibrosis, inflammation, all those things, and atrial function for atrial fibrillation, endothelial function. So there are a lot of mechanisms, but there have been direct electrophysiological studies looking at the action potential and how it affects it. So I think there's a good basis for believing it is having an effect on arrhythmias.
Thank you. We have lots of questions coming in. I'm very happy about that. We have almost 80 participants. So I would invite Bente Halvorsen to ask a question, if we can put her on.
Hi, great talk, very inspiring. I just wonder if there are any gender difference in the effect of the MRIs?
Well, there has been gender differences in heart failure, but in general, I would say from our trials so far, it's worked pretty well both in males and in females. There have been some reports from TopCat that it worked better in females, but in general, I think it's pretty effective in both genders.
Yeah, and then we have a question from Mohammed Fahad Tahir of the role of MRI in low ejection fraction. Is there a limit to how low the effects can be found in?
Well, we've studied it in HFrEF down to, 15, 20%. I don't know that there's a lower limit. I think it's effective across the entire, I think in fact it's effective across the entire range of ejection fractions, both in HFrEF down as far as you can go and in HFpEF. Now, maybe the evidence as you get above 60, ejection fraction 60 is a little questionable, but we think it works in HFrEF and HFpEF, though obviously in HFpEF is still controversial.
But this is an interesting point, and there was also a question by Mio Wang, and does MRA benefit both HFrEF and HFpEF? But we also have a divergence of the guidelines there, that the European guidelines for heart failure, they say, okay, it's a class 1 indication in HFrEF and the class 2B in HFrEF, but there is no statement in HFpEF, whereas the American guidelines, they have a class 2B indication also for HFpEF. This means also above 60. So what are your thoughts on this, and what is the basis, and why is there a difference between ESC and American guidelines?
Well, the trouble is, when we did the TopCat trial, as you know, the overall results were not positive, and that was because there were sites in Russia and the Republic of Georgia that didn't recruit patients who had really HFpEF. We know that because their survival was no different from age-matched controls that were normal. And above that, there were certain sites that we have evidence that they didn't take the study drug. So if you don't have the disease and you don't take the drug, you can't expect very much. And so that spoiled the overall results. Though when we looked from the Americas, it was positive, and in people in stratified who had a high BNP at baseline, it worked. So it's been controversial, and we are restudying this in the SPIRIT trial with the Swedish Heart Foundation and the NIH. And then, of course, there are non-steroidal studies. The Fine Art study with finerenone has just been completed randomization, and probably in another year or so, we'll have those results. SPIRIT will be another year or so. So I think we'll have more definitive information. And once we have more definitive information, hopefully the guidelines will converge. But given the fact that it's sort of a little shaky at the moment because of the TopCat results, you can understand that people look at the data a little differently.
So we have one more question, Dr. Suan Xu. Could you put her on camera, please, her or him? It regards anti-inflammatory and anti-fibrotic effects of finerenone. So are you there, Dr. Xu?
I'm here.
Please go ahead.
Okay. Yeah, my question is whether the nonsteroidal mineralocorticoid receptor agonist will be beneficial for the patients with the non-alcoholic fatty liver disease, because there's some evidence showing that this drug can also function beyond the cardiorenal parts.
Yeah, there was a report from the Fidelity, which is the combined analysis of Figaro and Fidelio, the whole study of finerenone, suggesting that there may be beneficial effects on the liver. There wasn't any definitive study, but certainly it looks like it's having an effect, but a lot more would have to be done before we have a really good answer. But certainly the non-steroidals affect inflammation very well in many parts of the systemic circulation. So I think it has great promise there. Also, as Dr. Yassir and his group have done, it has effects in the eye as well. So that there are lots of places for it.
So going back to that, I think in non-alcohol fatty liver disease is very important. Then there is also perhaps renal fibrosis. So you've been a pioneer in the study of cardiac fibrosis. And what are the most important clinical perspective in this field, but also perhaps involving the kidney? We have experts here in the audience in the field of CKD. So what is your take on that?
Well, certainly when you have cardiac fibrosis, you also have renal fibrosis. And in fact, they may sometimes be related. One of the things we're beginning to focus on is the role of the intestinal microbiome. And we know that in heart failure, as well as in renal disease, you get an increase in intestinal permeability. And that increase in intestinal permeability results in an increase in systemic LPS, lipoprotein polysaccharide, an increase in TMAO, transmethylamine oxide, and a decrease in short-chain fatty acids such as acetate and butyrate. And there's pretty clear evidence that when LPS and TMAO up and short-chain fatty acids are down, you get inflammation and fibrosis in the heart and the kidney. One of the points of attack may be through the intestinal microbiome, trying to decrease the intestinal permeability. So far, a lot of the efforts have been on prebiotics, probiotics, diet, fecal transplants, but I think there's tremendous opportunity with new pharmacologic and old pharmacologic agents that affect intestinal permeability for our patients with heart failure. And it goes beyond just heart failure and renal failure. There's good evidence that these substances also affect cognition. And we know that there's a tremendous increase in cognitive dysfunction in people who have heart failure. We know about it. Most people don't test for it because we haven't had much to do about it. But I think there are opportunities to do something about it. And it's really important as the population is getting older and the care of these patients has a tremendous economic burden. And I think that's one of the open challenges we have to see if we can stop this or decrease its progression. And I think there's a good chance we can, but we have to prove that.
Thank you. This is truly intriguing, I think, and it opens up new possibilities if we can just implement the therapy. We have a question from Mohammed Fad Tahir. So Mohammed, could you prepare yourself to ask your question? It regards dose and diuretic action. So there you are.
Dr. Tahir, you are unmuted, so you can pose your question.
Yes. Okay, I got a question that why don't we use high-dose MRAs in patients with heart failure for a good diuretic action?
Well, it's a balance. Certainly, the higher dose you get, probably more diuresis, but you pay the price of hyperkalemia. So that's why we did the dose finding trial. And we saw that if you go up higher, you have greater efficacy, but you pay the price with a greater risk of hyperkalemia. So if the patient is tolerating the doses, you could go up as long as you're monitoring and make sure that they don't have hyperkalemia. But you want to keep the potassium, I think, somewhere between 4 and 4.5. As you get to 5 and above, there's a clear increase in risk, especially when people have heart failure or renal disease. So you can do it. And now we have the Sglt2 inhibitors, and we know that combined, there's less hyperkalemia and maybe less need for diuresis. You can get rid of some of the diuretics. So I think we have exciting possibilities, and more people can tolerate and stay on an MRA. A lot of the times people just have been too frightened to start. And then often when they start, they see a rise in creatinine, which is hemodynamically mediated, and they stop where they should really persist and continue, unless it really drops by about 30%, the GFR or more.
Maybe in the same direction, Bertram, do you think there are differences between predominantly left heart and right heart failure? Because for right heart failure, we don't have a lot of data. And
so there isn't a lot of data, as you say, but the little data we have, it does seem to work in right heart failure as well, but that's certainly an area that needs more work. But the little bit we have says it does work. And when you talk about right heart failure, that is certainly a very important determinant of intestinal dysfunction, which we were talking about. As soon as you have right heart failure, you get edema of the intestine, and then all of that permeability is even worse than in other parts, even than the left.
So questions keep coming in from the audience, and Dr. Miao Wang. So I'll read the question this time. Asks that does MRA have a key role? Does MRA benefit heart failure post myocardial infarction more than heart failure for other reasons?
I don't know that it's more, but certainly in the Ephesus trial, we showed that heart failure early on post-infarction was very beneficial. And I don't know that it's more, but it certainly wherever you have heart failure, it is beneficial post-infarction or by idiopathic or cardiomyopathy, HFpEF, HFrEF. I think it works.
So I'm going to take over asking the questions for a little while, and we'll talk about the clinical trials. And you have been a principal investigator of seminal trials. We talked about the very successful ones. What has been the most successful, and has there been any disappointments?
Well, we talked about the RALS trial, which I think was the most successful in many ways. The SOLVE trial was very important. The most disappointing, we already mentioned, which is TopCat, is that we really believed it should have been positive. I think it will be positive when it's done again, but because of the difficulties we had in Russia and Georgia, and let me say, it's not all Russia or Georgia. It was just the sites that were chosen. A lot of these sites that were chosen didn't have a lot of experience in randomizing patients and in being in clinical trials. So there are many good Russian sites, many good sites in Republic of Georgia. So we just happened to, the NIH, when they picked the sites, I think money was very important, and they went to sites that were less experienced and maybe got a good short-term economic deal and paid a long-term price. So that was very disappointing.
So, Kema, do you think that maybe the SPIRIT trial, for those coming in, maybe you just want to explain a little bit about that? Do you think a registry-based trial trying MRAs in HFpEF will work better than the TopCat?
Well, registry-based trials are very exciting, and the group in Sweden with Lars Lund have really, and Stefan James have really been pioneered, and we're working with them, with the NIH, and we think it has a role. There are pluses and minuses. Obviously, a pragmatic trial is more real world in many ways, but there are more chances of crossovers. There's a little less supervision, and we just did the ACCOMPLISH trial where we looked at torsemide versus furosemide, and we didn't see a difference, but I'm not 100% sure that that's the right answer because it was a very pragmatic trial, lots of crossovers. So I think the best evidence is from the strict prospective randomized trials. I think registry trials, though, allow us to do things in populations and easier. So we'll just have to see. But I think we're going to have answers because, as I mentioned, there's this fine arts trial in over 5,000, close to 6,000 patients with HFpEF, and we have SPIRIT in a HFrEF. And there's a German SPIRIT trial as well with very similar. So I think in the next few years, we will have more evidence.
So before I let Johann come in and give the questions that you're asking, I just would like to topic that I'm very fascinated by. That is, if you can prevent by MRAs the transition from hypertension, which is really a worldwide problem, to going into heart failure, whether it's REF or PEF. What are your thoughts on that?
I think that's the future of MRAs. Once you have heart failure, there are often irreversible changes. There are changes in fibrosis that are very difficult to change, and it would be much better to prevent. And obviously, to think about prevention, it has to be well tolerable. It has to be inexpensive. but I think we're getting there with the tolerability, with some of the non-steroidals and ASIs. They may not be cost effective yet, they're expensive, but we have drugs like eplerenone that don't have some of the sexual related side effects of spironolactone that is pretty effective. It was really studied in hypertension, and even though it's less effective in resistant hypertension than spironolactone, it is effective in lowering blood pressure down to goals. And I think there's a great opportunity. And in fact, not an opportunity. I think if we don't do it, we're going to continue to have heart failure. Dr. Diaz in Spain has written in the European Heart Journal recently about hypertensive heart disease, that despite the things we are currently doing with hypertension, there's a very high incidence of new onset heart failure, especially in the elderly. And I think there's about a 20% incidence of unsuspected and undetected primary aldosteronism. There are, as you get older, there's upregulation of the mineralocorticoid receptor, as Dr. Bauersachs has written about. And we know and talked about the intestinal microbiome. As you get older, it gets leakier. And when you have long-standing hypertension, it also causes intestinal permeability. So I think there are a lot of reasons to think that if you want to prevent heart failure, that using an MRA, maybe a non-steroidal or an aldosterone synthase, will be a very good strategy. If there's aldosterone there or the MR is upregulated, no matter what you do for other mechanisms in lowering blood pressure, if you don't take care of the aldosterone or the MR, there's going to be continued fibrosis and inflammation, and you're going to get heart failure. So I think it will have a very important role. Obviously, we need to do definitive trials to show the relative safety, cost effectiveness, and things will have to be cost effective if they're going to be used in prevention. And some of the newer agents may be exciting, but while they're proprietary, they're not going to be terribly cost effective yet, but eventually they will be.
Thank you very much. So I think we have to go through several questions that are in the chat. So one, perhaps I think we have already answered, are MRAs equally effective in patients having heart failure with myocardial infarction as it's related to remodeling? Yes, we have already mentioned that it's affected also after myocardial infarction. Another question is here, can you say anything about the relative potencies of the respective antifibrotic drugs, ACE inhibition, ARB, and the various MRAs currently available?
Well, I think the MRAs above and beyond ACEs and ARBs have been shown to decrease fibrosis. I think that's very clear. All of our studies have been on top of ACEs and ARBs. So I think it's very clear that we can reduce inflammation and fibrosis above and beyond ACEs and ARBs and sacubitril/valsartan.
So it's not a question of either MRA or ARB, is a question of giving both.
Yes. Yes.
And another question here regarding the inflammation is, do MRAs have a key role in metabolic disease by suppressing inflammation in the adipose tissue?
Well, I think they do. We know that in people with obesity, visceral obesity, and the metabolic syndrome, that aldosterone levels are increased, and there is decreased changes in brown fat. So I think it has a role. There have been several articles written about the role of MRAs in obesity. We need further studies. Now we have evidence from the GLP-1 receptor agonists of weight loss and affecting fat. And we know that that has had a very profound effect on cardiovascular events. So inflammation and obesity is a really important role, and whether the MRAs in combination with maybe a GLP-1 receptor agonist, that could be another area that we have to explore.
Yeah, thank you. And Anne Pissar had here the question, shall we advocate in clinic for aldosterone measurement in potential patients in order to better target MRA treatment?
Well, that hasn't worked out very well, measuring MRAs. Maybe someone can answer better, but I think we talked about it before. Even if the aldosterone levels are low, MR expression can be up. So you can have benefits even with relatively low serum levels of aldosterone. But in some patients, it may be some help. But so far, it hasn't turned out, to my knowledge, to be that useful.
In patients with heart failure, clearly, I think we don't do it. Maybe in patients with hypertension to the
Yes. So I mentioned primary aldosterone is about 20%, but unfortunately, except in specialized centers, it's complicated to look at it. It's not. You can get an idea from low renin and high aldosterone, but then you need provocative testing, and most people don't do it. So if you don't do it and don't detect it, you don't treat it. So there are lots of people walking around who have primary aldosteronism, who aren't being treated and have progression of fibrosis and inflammation. And that's one of the reasons why we believe that MRAs will be useful in prevention, because it's not going to change in the near future. There's going to be this high percentage of people with undetected primary aldo. It's just too complicated, given the tremendous pressures people have now to see patients in 10, 15 minutes and get on to the next because of economics.
Yeah, thanks. So there are the questions really running on and coming in large quantities. So Konstantinos Pamporis asked, Dr. Pitt, are there any phase 3 clinical trials currently running on new MRAs in HFrEF?
In HFrEF, I don't know about. I know that people are talking about doing some trials with some of the non-steroidals, but I don't know any particular details. I did mention the HFpEF trial, that's fine arts, which is almost done, but I think there will be some study. I think there is some study being initiated in finerenone in people with HFrEF who are intolerant of an MRA, maybe. I'm not part of it, so I don't know any of the details.
Maybe John Cleland can ask his question. So John, are you there? Perhaps Amelia can unmute you.
Great to see you and hear you, Bert. And I know that you also have an interest in Sglt2 inhibitors. Our friend Milton Packer is very concerned about the interaction between intravenous iron and Sglt2 inhibitors. I think it might actually be synergistic and a good thing. Do you think it's a good thing, a bad thing, or we just don't know?
Well, I think as far as the MRAs, the SGLT, I should say T rather than 2, because I think the 1+2 has an advantage. In fact, we just have a paper online in JACC Heart Failure. It's entitled 1+2 may be greater than 2, the role of SGLT1/2 inhibition. And we have evidence from the SCORED trial that the SGLT1 component seems to reduce stroke and MI about 30%. We don't see that with the selective SGLT2 inhibitors, empagliflozin and dapagliflozin. We do see it with canagliflozin, but canagliflozin has more SGLT1 inhibition than EMPA or DAPA, not as much as sotagliflozin, but more. And we've also recently published some of the data on the early outcomes of the SOLOIST trial, where we randomized people before they were discharged, and we took the subset randomized before discharge in a few days, and we saw a striking reduction in events in 30 and 90 days, including a reduction in total mortality at 90 days. And so far, when we've looked at the comparative results of empagliflozin in IMPULSE and dapagliflozin in DELIVER, they're both effective, but they're not as effective so soon and so dramatically. So unless I would do a direct comparative trial, I don't know the true answer. But at the moment, I think there is an advantage of the SGLT1. And I think giving the either SGLT2 or 1,2 in conjunction with an MRA is certainly beneficial in reducing the incidence of hyperkalemia, but I think has added efficacy and synergy in together.
And the changes in hematocrit are similar with SGLT non-selective and 2 selective agents?
Well, I'm not so sure the changes. So one of the things we believe about the SGLT1 component, as we mentioned, the intestinal microbiome, SGLT1 is expressed in the intestine, whereas SGLT2 is not. We know that the SGLT2 inhibitors do have an effect on the microbiome, but we think likely the SGLT1/2s are greater, that there hasn't been any direct comparative trials, so it's still speculative. But when you block glucose in the intestine, you shift it down into the lower intestines and you change the pH, you change the whole microbiome. And I have to believe that's a little bit more effective than just the SGLT2s.
So I'm taking over here now. This is very interactive, and that's so fantastic. So let's move over to the gold medal that you won from the ESC this year. You received many awards. Which one is the most important for you?
Well, I think there are two. Johann mentioned the Herrick Award I got from the American Heart Association several years ago. And that was important to me because my mentor, Dr. Herman Blumgart, had been one of the prior recipients. And certainly the ESC Gold Medal was a great thrill, being an American and getting it from the ESC. And I've gone to many ESC meetings and always looked with awe at some of the people that have gotten it, and just was delighted and honored to be the recipient, or one of the recipients this year.
And I can see that your son, who was also with us in Amsterdam, is here present in the dialogue, which is fantastic. So time is running. I'm sure we could go on all night with additional questions, but I would like to close by asking a final question to you and to all our guests. What do you have any suggestions for the future European Heart Journal dialogues?
Well, I think the dialogue is great, and I think the questions are really what makes it great. And having people like Johann, who are experts in asking questions and the subject, really is what makes it really good. So I think the format as you have it is good. Having an expert who asks the questions and having an audience that is really outstanding and can ask questions, I think it's, I don't know that there's much I would change.
So thank you. And then please help us with suggestions on the chat. We will pick them up and look at them. We really would appreciate input. So this, as I said, been a fantastic session. Thank you very much, Professor Pitt. Thank you, everyone in the audience, for being so interactive and lively. So this now concludes our second dialogue for this autumn. And I'm happy to announce that the next dialogue will be on October 26th at 4 o'clock CET. So please welcome to join us then at the end of October. So thank you so much for joining, and please contact us with suggestions for the next dialogue. Thank you so much.
Well, thank you for the honor of allowing me to participate. It was really a thrill. Thank you.
Thank you.
Thank you.